if you have time, infectious pathologies as well. Okay. And what we need to know about glomerular diseases, we have this glomerulonephritis, and you need to know these three major groups. We have primary. Prepare texting. All right. Hi, everybody. You need to know the groups, okay? We have primary glomerulonephritis, so we have secondary, which are related to systemic disorders, like systemic autoimmune disorders, for example, lupus is very common in this list because the most common cause of death in lupus is renal failure, right? So we need to know what is the mechanism of this kidney damage. Diabetic nephropathy is there as well, amyloidosis, polyarteritis nodosa, you remember this, right? Most of the vasculitis we've discussed, they lead to complication in kidney, and that will be glomerulonephritis. And very rare cases is the third group, hereditary nephritis. Okay, very rare they are, but you should know that we have type of glomerulonephritis that are hereditary. That is a major group where you find all diseases. But there's other classification as well, where glomerulonephritis kidney disorders are divided in two syndromes. To distinguish actually those disorders based on pathogenesis, you need to understand this syndrome. We have nephrotic syndrome and we have nephritic syndrome. You see, nephrotic and nephritic. What is major difference between them? Actually, that is normal. Before we talk about diseases, you need to know normal anatomy, histology, and physiology. We agree on it, and I won't discuss anything here, but I will revise the structure. What you need to know to understand glomerulonephritis and to understand nephrotic and nephritic syndrome. Actually, three things are important here. Basement membrane, you need to know. On top of basement membrane, inside you have endothelial cell, okay? Endothelial cells we have, because you know they are capillaries in the glomeruli, right? So three layers are important: endothelial cells, basement membrane, and epithelial cells. Epithelial cells are these podocytes, okay, podocytes, you know, and podocytes is visceral epithelial cells, and we have parietal epithelial cells as well. And don't get confused here. Parietal epithelial cells are epithelial cells that line Bowman capsule, right? We don't need this. Only thing we look at in this disorder is this part, right? That is endothelial cell, basement membrane, and epithelial cell. Epithelial cell and podocyte is the same. If you understand this three-layered structure, then anything else is really easy, okay? And last part here, mesangial cells, you should know. What is mesangial cells? Mesangial cells actually put together this capillary loop, right? That is important. So endothelial cell, epithelial cell, basement membrane, and mesangial cell. When you understand it, the next part is to distinguish between nephrotic and nephritic syndrome. Nephrotic syndrome, we already discussed, is when patients lose protein, okay, more than 3.5 grams a day. If patient lose this protein, that is nephrotic syndrome, and less than 3.5 is nephritic syndrome. Nephritic means there is inflammation. Next topic I want to pay attention is terminology, not to get confused, okay? And how these disorders or this glomerulonephritis and all these nephropathies are called. They are called according to the percentage of glomeruli that are affected, okay? Here you need to know what is focal and diffuse. Why? Because we have focal segmental glomerulosclerosis, that is one disease. And what means focal there? Focal, when we mention focal, it means amount of this glomeruli, right? Focal means when you have affected less than 50%. If you have, when you look this the kidney tissue under the microscope and look at this glomeruli, If you see that less than 50% of glomeruli are damaged, that is focal disease. And if you have more than 50%, you can say that disease is damaged. Lesion is diffuse, okay? Massive lesion you have there, so it is diffuse. So in disease, for example, focal segmental glomerulosclerosis means only 50% or less than 50% are affected. Focal segmental is, segmental means when you have, we talk about one glomeruli, okay? And in this one glomerula, only segment of the glomerula is affected, okay? Injury in which glomerular tuft can be, okay? So focal means amount of the glomeruli affected, and segmental or global means how big part of the glomeruli is affected. Okay, segmental means if you have only small part, a small portion of the glomeruli affected, and global means when whole glomeruli is affected. Then, according to the characteristic of lesion, that is also important, okay? What type of lesion you find? Here we will find crescent, okay? Crescent formation, for example, rapidly progressive glomerulonephritis, that is end-stage disease usually. You will find the crescent formation. Sclerosis you can find as well. What is sclerosis? Sclerosis means, guys, when you have deposition of collagen, right? I'm now just giving you overview, okay, terminology, and then I will repeat again. Extracapillary and endocapillary. That is also important. You need to know where exactly disease is localized. Okay, that is also important. And then in terms of glomerular disorders, terminology, you know what it means. Proliferative, you see here membranous, membranoproliferative, focal segmental, crescent, and secondary glomerular disease. I will overview them and then start. Proliferative, wherever you hear this word, proliferative means this inflammation definitely, okay? Because proliferation you find in inflammatory conditions, proliferation of cells, proliferation of mesenchymal cells, proliferation of white blood cells, for example, neutrophilic infiltration you will find there, okay? So proliferative glomerulonephritis means there's definitely inflammation there as well. And nephritic will be most likely. Membranous, wherever you find membranous, be it membranous nephropathy or membranoproliferative glomerulonephritis, for example, means that you have thickening of basement membrane, capillary basement membrane, I mean. So you remember the three-layer, right? Endothelial cell, basement membrane, and epithelial cell, podocyte. Membranous, wherever you hear membrane, that means thickening of the basement membrane. Under light microscope, you see that capillary basement membrane is thick. And why usually it occurs? It occurs because of deposition of immune complexes, okay? So you should know pathogenesis, right? Proliferation if there's inflammation. Membranous means you have thickening of the basement membrane. For that reason, filtration rate is low, okay? You understand that in normal condition, this basement membrane should be very thin to filtrate this blood. And in this case, it thickened, and you should know that it usually occurs because of immune complex deposition. And then I will discuss pathogenesis, why you have immune complex deposition usually. Focal segmental glomerulosclerosis, you know this as well. Focal segmental means only less than 50% of glomeruli are affected, and segmental means you will see just small portion of the glomeruli will be affected. Crescentic glomerulonephritis is this most dangerous condition. Wherever you find crescent, that means it is very progressive, rapidly progressive disease, and you will find the proliferation of parietal epithelial cells around glomerulus. Okay, and one thing I will say now and will repeat again. There is question usually, what is composition of crescent? What is crescent? Crescent, guys, means you should find there fibrin, and macrophage. Okay, present formation. It's fibrin deposition and macrophages you should find there. But if you have sclerosis, sclerosis means you should find their collagen, and don't make mistake there. Okay, there will be. It's common question actually, and shouldn't think that both look like pink. You know, the pink deposition and under the light microscope. And you should know that it is collagen you find if it is sclerotic, and in crescent it is pink, but you should know that it is fibrin, and you should find macrophage there as well. Okay, and secondary, primary and secondary, you should know the meaning of the word as well. Primary is when it is related to glomeruli itself, okay? It arises from glomeruli, and secondary glomerular disease is when it is complications usually. For example, of the tumor or any systemic condition, or most commonly it is diabetes mellitus, okay? That is terminology, just to understand what we are going to talk about. General information, basic principle is also, when we are talking about glomerulonephritis, guys, very, very important is to know laboratory studies and what diagnostic tools we use, okay? Routine studies on biopsy specimen. You need to look at the biopsy. You cannot make diagnosis of glomerulonephritis if you don't make biopsy and you don't have hematoxylin eosin images, okay? If you don't have IF, immunofluorescence stain, and in rare cases, it is electron microscopy. Okay, electron microscopy examination is very expensive, and in Georgia, we don't make it, okay? But in developing rich countries, they usually do it, okay? And it's very expensive method. But two definitely you need to make. Hematoxylin eosin, histopathological examination you need to have, and immunofluorescence examination. But for exam purposes and for learning purposes, when you study glomerulonephritis, okay, nephropathy usually, you need to know what is hematoxylin eosin features, histopathology features. You should know what is immunofluorescence feature, and you should know what is EM feature. Okay, these three you need to memorize. Okay, that is how we examine and how we study this glomerulonephritis. What is EM actually? I would mention here. Detects submicroscopic defects. Submicroscopic, you know, right? Whatever you cannot recognize on hematoxylin eosin staining, you can see definitely on EM. It also shows you the cellular destruction as well as localization of IC. IC is immune complex deposition, right? Immune complex deposition is very important in glomerulonephritis. We have many disorders, and you need to know we distinguish disorders according to this deposition, okay? And location. Immune complex deposition, we distinguish based on location. Where is it possible to deposit these complexes? One possibility is to deposit under the endothelium, right? So you will have subendothelial immune complexes under the epithelium. You can have subendothelial, epithelial immune complexes you will have, or you can have intramembranous. Okay, intramembranous. And fourth one is mesangial. Okay, you understand now why it's important to understand histology and anatomy. Okay, because based on location where you find this immune complex deposition, you can make a diagnosis as well as identify etiology. Okay, etiology. So it will help you to make diagnosis. So studies, the routine studies on biopsy specimens is hematoxylin eosin, IF, EM, and we need to look at this location where immune complexes are deposited. Mechanism producing glomerular disease. That is also general principle, and I always pay attention to these basic principles, because if you understand basic principles, then it is very easy to memorize these disorders, because many disorders, many glomerulonephritis we have, and if you don't understand principle and logic there, you will definitely get confused. So mechanisms producing glomerular diseases. One is immunocomplexes, immune complex disorder we have, okay? And what is immunocomplex? You know it already. We need to know this complement factors. Also the C3 convertase, I will mention it as well. Antibodies is also that can cause damage. Antibodies usually damage basement membrane, okay, the glomerular basement membrane. And most commonly, you find it in Goodpasture syndrome, right? Goodpasture syndrome, example is given here. And third mechanism is T cell production of cytokines. So not T cell actually damage glomeruli, but cytokines. Okay, cytokines are important here. Cytokines cause GBM, glomerular basement membrane, to lose its charge. For that reason, this cytokine, if you have overproduction of the cytokines, guys, it will lose. It will lead to protein loss. Okay, so nephrotic syndrome, consequence of this T cell production of cytokines, will result in nephrotic syndrome. For example, one will be minimal change disease. Okay, but T cell production of cytokines, when I'm saying, you should think here about Hodgkin lymphoma. Okay, Hodgkin lymphoma is disease where you have these lymphocytes, okay, the T cell lymphocytes, and we have these tumor cells, Reed-Steinberg cells, you remember, and Reed-Steinberg cells are malignant cells which produce a huge amount of cytokines, and these cytokines actually lead to protein loss, damage of the podocytes, and finally will lead to loss of podocytes and protein loss. Minimal change disease is example. So pathogenesis is super interesting and the glomerulonephritis is very interesting disorders and logical, by the way. So 3 mechanisms. Keep in mind that immune complexes we will talk about, antibodies we will talk about, and cytokines. Now, clinical manifestation of glomerular disease, that is also general principle. Clinical manifestation. When I talked about nephritic and nephrotic syndrome, and you see here is a third chronic glomerulonephritis as well, they are all clinical manifestation. And let's discuss it. Nephritic syndrome definition is glomerular injuries primarily due to neutrophils, nephritic. Itis means there is inflammation. So what causes inflammation? It is acute process, and you definitely need to find neutrophils there. Clinical laboratory finding is interesting as well. Why? We have already experienced that in clinical cases, you have all this information mentioned and you need to recognize them, these keywords, and it helps you to understand either it is nephrotic or nephritic. And when you know that it is nephritic or nephrotic, then you will look for diseases based on more detailed information, whatever is given in clinical case. So nephritic syndrome, when we are talking about it, hypertension, definitely. You will have this retention, salt retention, so you have water retention there. And finally, to lead to hypertension, you know that mechanism. Periorbital puffiness, that is important. Salt retention you have, and periorbital, that is important. Periorbital means in loose connective tissue, usually you have accumulation of water, okay? Periorbital puffiness around the eye, when you see this puffiness, that is typical to nephritic syndrome, usually, okay? And in some cases, edema is more generalized. In some cases, that means rarely you find generalized edema here. Generalized edema, most likely you will find in nephrotic syndrome, where you lose a lot of protein. And sodium retention, increased plasma hydrostatic pressure, that you understand as well. Oliguria is important. Definitely there will be mentioned oliguria. What is oliguria? It is reduced production of urine, okay, less than 400 milliliter a day is oliguria, decreased amount of urine, and due to decrease of GFR. You understand, right? You have damage of the glomeruli and filtration rate will decrease. So that is very logical, okay? Tubular function intact. You remember in acute renal failure, we have pre-renal, post-renal, and intrarenal, and there was a laboratory finding was different based on tubular damage, right? Do you remember that? And in this case, filtration rate is increased, it changed actually, okay, decreased GFRs, but tubular function will be intact. For that reason, I will give you a test and you should solve what laboratory finding are you expecting, okay? And we discussed it in acute renal failure. And all of you here know this. Hematuria, guys. Hematuria is key information when we are talking about nephritic syndrome. There is inflammation, okay? Inflammation, and for that reason, you lose blood. Hematuria means you find blood in urine, and dysmorphic red blood cells. Dysmorphic red blood cells are present with irregular membranes, yes, and glomeruli become inflamed from IC deposition causing damage to red blood cell. That is complex mechanism, but you should understand that hematonephritic syndrome or nephrotic syndrome both can be caused with immune complex deposition. And if you have this, if you damage, for example, blood vessels and red blood cells, you will find these red blood cells in the urine, okay? And you will have this hematuria. You should find, guys, red blood cell cast as well, okay? Hematuria means you can find red blood cell cast as well. And cast, you know what is, right? That is red blood cells that are stuck in the tubules and tubular shape casts. You end up in the urine. Neutrophils are present in the urine sediment. Urine sediment neutrophils, it is logical as well, right? Nephritic syndrome, you have proliferation. Neutrophils usually cause this inflammation, and definitely you need to find these neutrophils, particularly in IC types, immune complex types, okay? That is very logical. Red blood cell cast I mentioned already. Key finding, occasionally white blood cell casts are also present. That is also important information where students get confused, okay? You might find casts. We are not talking about red blood cells, but we are talking about casts, okay? Red blood cell casts you definitely need to find, but occasionally white blood cell casts are also present. Neutrophils are white blood cells, and this, sorry. Sorry, guys. So casts, pay attention. It is not cells because neutrophils are usually present in urine sediment, but white blood cell casts rarely present, but you can find it as well. But red blood cell casts are key finding. That is one thing. Proteinuria, guys. Proteinuria, that is what confuses students as well. And why? Proteinuria, you remember I mentioned that you find it in nephrotic syndrome, right? And this proteinuria you can find in nephritic syndrome as well. But important to say, proteinuria is more than 150 milligram a day, but less than 3.5 gram. So wherever you find some complex cases, for example, they give you this confusing information that patient has proteinuria, and you immediately think that it can be nephrotic syndrome, but it is not. So in this case, always pay attention amount of protein they lose daily. Okay, more than 150 mg, but less than 3.5. So 3.5 is key here. Azotemia is normal because you have damage of the glomeruli, and azotemia is present with BUN ratio will be greater than 15. we know this mechanism. Tubular function is intact. Here is mentioned tubular function, and tubular function is intact in both oliguria, but tubular function is intact, azotemia, but tubular function is intact. So that is important. Why is it important? It is important because we need to make differential diagnosis, guys. Where is the problem? In the glomeruli, or is it tubular interstitial disease? All right. Primary nephritic types of glomerular disease, that is disorders. What are causes of nephritic syndromes is mentioned here. Most of the are vasculitis. You remember vaginous granulomatosis, microscopic cholangitis, Schack-Strauss. Good pasture is systemic disorder. Alport syndrome, you remember it is in third group that was inherited. Immunoglobulin A, it is also, it is not immune complex. It is immune complex actually, but slightly different mechanism. And post-streptococcal glomerulonephritis. I will discuss it. And you see here RPGN, rapidly progressive glomerulonephritis. We will talk about rapidly progressive glomerulonephritis, and I mentioned already crescentic nephropathy is this. Okay, this is most severe. When patient has rapidly progressive glomerulonephritis, it is, we treat it with chemotherapy. It is very, very severe condition. What is etiologies of rapidly progressive glomerulonephritis? I will just overview here. We have etiologies can be distinguished based on immunofluorescence type. Do you remember? We need to look at hematoxylinosin, we need to look at immunofluorescence, and we need to look at EM, electron microscopy. And here in this inflammatory conditions, usually immunofluorescence is important. And you should know that 3 types of immunofluorescence in general we have. 3 types, 3 patterns only. That is linear, granular, and negative. Linear means linear is just, it is very prominent lines. You will see there's a highlight these lines. Immunofluorescence, you know what is, right? You have seen the image. Linear means always, guys, always you have antibodies against basement membrane. Okay, that's why it gives this linear pattern. And granular means immune complex deposition you have, and it is scattered, okay? It's scattered and dispersed throughout the glomeruli. So for that reason, it gives you granular, just grainy appearance, you will find there. And negative immunofluorescence means immunofluorescence you don't have immune complexes. So further, the post-immune means negative, but post-immune means you don't have immune complexes, but you definitely need to find the CANCA, PANCA. Okay, so PANCA, CANCA positive nephropathies usually are negative IF. It does not give you fluorescence, but there you can find antibodies, right? And Cianca, Pianca, you know what it is. We will revise it again. You will find in vasculitis. I hope you revised vasculitis here. I will show it as well. And let me discuss disorders now, what you need to know about nephritic syndrome, okay? First one, let me see here. Post-streptococcal glomerulonephritis, I will talk about it, and this description is quite enough here. And I will talk and you will read as well. You can read it in Golian, Robin Patoma, and particularly very good is post summary, first aid. I will send at the end of this lecture everything. Okay. So when we are talking about post-streptococcal glomerulonephritis, that is first and most common type of nephritic syndrome. Nephritic, we agree that it is inflammation. And what happens there? Actually, most commonly you find it in kids, guys. I imagine kid and adult. You can find it in adult as well. Just a moment, guys. Kid and adult, it is important. Classical case, what you find post-streptococcal glomerulonephritis, you will find in kid, okay? But you can find in the children as well, in adults as well. But what is the difference? In children, it is you can treat it. It is treatable, all right? It has very good response. But if there's in adults, it is not treated. That does not have good response. That is important to know. Now, when we talk about post-streptococcal glomerulonephritis, guys, I want you to pay attention about the time. 2-3 weeks. Just pay attention, 2-3 weeks. I need to emphasize this information because students usually don't pay attention to it. Imagine patient has pharyngitis, child has pharyngitis or some skin infection, okay, and recovered. But after 2-3 weeks, okay, later, 2-3 weeks later, patient has hematuria. Okay, hematuria, hypertension, pitting edema, or the edema around the periorbital edema. And what happens? What happens? You should know here that it is post-streptococcal glomerulonephritis. And what is important to know here? Post-streptococcal glomerulonephritis is caused by group A, beta hemolytic streptococci. Okay, you know it already. And the post-streptococcal glomerulonephritis, here one important thing you need to remember, M protein. I believe that most of you know it, but for exam purposes and for board exam, it is not only my exam, in general and the board exam, they ask this question. What is virulence factor that cause these symptoms and disease? That is M protein, and you know that group A beta hemolytic strain carry this M protein, and we discussed in cardiac pathology. Do you remember? That endocarditis, rheumatic fever and stuff. So M protein increase risk of development of nephrotic syndrome. And when it happens, it happens usually after 2-3 weeks, 2-3 weeks. And these strains usually are nephrogenic strains, you should know. So I will revise, just I want you to understand that you have child who had this pharyngitis or dermatitis or some skin infection and recovered, okay? And 2-3 weeks later, patient has brown colored urine, cola colored urine. You can memorize like this. The child had this hematuria, has all the classical clinical symptoms that we mentioned in the beginning. Hematuria you should have, oliguria, hypertension, periorbital edema. All right, that is really important, guys. So when you have, I will mention that when you find it in adults, it usually can complicate with rapidly progressive glomerulonephritis. Okay, in some cases, in adults it is dangerous anyway. Now, how are you going to make diagnosis? Clinical history is important. Two weeks ago, the patient had this pharyngitis. And what are you going to see on the microscope? You take this biopsy sample, and you definitely need to find hypercellular inflamed glomerulus. Hypercellular is keyword. Multiple cells you should find in glomeruli. At the high power field, you will see there is hypercellular. That means there is inflammation. Again, this and why do you have this inflammation, guys? It is immune complex deposition cause inflammation, right? So this is immune complex disease. So pathogenesis, you remember? So post-streptococcal glomerulonephritis is immune complex disease, and this immune complex deposition will lead to inflammation. What type of immunofluorescence are you going to see? It is granular immunofluorescence, okay? Granular immunofluorescence, because immune complexes usually give granular immunofluorescence. And it is important under microscope, under the fluorescent microscope, you see the granular immunofluorescence. You already know that disease is immune complex. And which type immune complex disease, then you make differential diagnosis. So granular immunofluorescence is because of immune complex disease. Then we need to know EM finding, right? Electron microscope. Electron microscope, guys, here you should find hump, okay? Epithelial hump on electron microscopy. And here is the picture, how it looks, a hump. You see, this is basement membrane, and you see the hump of the deposition. Hump means, guys, you know what the meaning of hump. And this is immune complex, okay? Deposition of immune complex, and it has such a pattern, for example, okay? Don't pay attention to this picture, that is crescentic formation. Post-streptococcal glomerulonephritis and hump. IM protein is mentioned here. It is from Gojan, you will read. And when I'm talking about hump, guys, you need to know where, please pay attention, where deposit these immune complexes. Epithelial, subepithelial hump, you should find. These immune complexes usually deposit under the epithelium, under the, that means podocyte, right? Epithelium is a podocyte. And immune complexes, what happens, why you have this hump? When it starts deposition in the beginning, for example, okay, what happens here? In this disorder, immune complexes actually start subendothelial, okay, it starts subendothelial, but as it pile up, okay, it work their way up, they say, and as it pile up, it will reach to epithelium, okay? That is important. Subepithelial hump you have, but you should know that immune complexes usually start deposit under the endothelium, and it pile up and reach to epithelium, okay? That is important. Eventually, what's going to happen is this deposit will simply just dissipate into the space and disappear. That is also important. Why you need to know, guys? Because post-streptococcal glomerulonephritis is immune complex disease. If you find the subendothelial immune complex deposition, but after time, it disappears itself, okay? Even if you don't treat, it disappears itself, okay? It happens. But if you don't treat adult variant, in adults, if you don't treat, it will progress to renal failure. That is really, really important. So we discussed post-streptococcal glomerulonephritis, and you should know that it is caused by group A, beta hemolytic strain. A virulence factor is M protein. You should find it in children. In children, you don't need to treat, but in adults, it will lead to renal failure. Next important information. Immunofluorescence is important. Granular immunofluorescence you should find, and you should know that it is immune complex disease. All right. Then it's next disorder, guys. Next disorder we are going to talk is rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. Do you remember I mentioned that rapidly progressive word shows itself. It progresses so fast that chemotherapy, we treat it with chemotherapy. Imagine, it is like cancer. Only difference is it does not metastasize, and irreversible changes it causes to the kidney. Now, feared complication of post-streptococcal glomerulonephritis in adults is rapidly progressive glomerulonephritis. And what is this rapidly progressive glomerulonephritis? It will lead to renal failure in a week, 2 months, guys. You see, in a week, in 2 weeks, it is possible even, and maximum 6 months. So for that reason, you immediately need to treat with steroids and chemotherapy. How you are going to make diagnosis? You take biopsy and you find crescents. Crescents, that is keyword. Crescent you should find in Bowman space. And crescent, what is the question will be? What is crescent made up of?
Fibrin and macrophages.
Fibrin and macrophages, yes, that's true. And where is collagen?
Crescents. Sorry,
Collagen.
sclerosis.
Collagen was in sclerosis, right? Sclerosis, yes. For example, sclerosis, focal segmental glomerulosclerosis you find, or in the diabetes mellitus, there's collagen deposition. And here is fibrin and macrophages. That is important. Okay, so next thing we need, and the biopsy, what you need to know, immunofluorescence, EM, and EM, and what else? Again, hematoxylineosin, EM, and immunofluorescence. These three things are important. And here we mentioned already that immunofluorescence, what type of immunofluorescence are you going to find here in rapidly progressive? I need to emphasize here. Immunofluorescence, guys, we mentioned already that you can have linear, you can have granular, and you can have negative, right? Pulse immune. And if it is linear, it's important. If it is linear, you will have Goodpasture syndrome. Okay, Goodpasture syndrome. And what happens? Do you remember from lung pathology, in respiratory pathology, what was Goodpasture syndrome? There was antibodies against what? Against basement membrane. Okay, particularly collagen, right? Against collagen. So you remember linear immunofluorescence, where we mentioned about linear immunofluorescence. That means you have antibodies against basement membrane. That's why example will be Goodpasture syndrome, because Goodpasture syndrome is disease where you have antibodies against collagen in both glomerular and alveolar basement membrane. Okay, do you remember? Goodpasture syndrome. Goodpasture syndrome was discussed in the alveolar some respiratory pathology, because it affects basement membrane collagen, what we have in basement membrane, and it will affect kidney and lung equally. So clinically, what you will have hematuria. You will have hematuria. It's nephritic syndrome, okay, and renal involvement will be there, and hemoptysis. Hemoptysis, you know what is. What is? Remind me, please. Hemoptysis. Hemoptysis. What was? Blood in when you cough, right? That is hemoptysis. So pulmonary involvement. It shows the pulmonary involvement. Where are you going to find this Goodpasture syndrome? Goodpasture syndrome you usually find in young adults. Okay, young adults. So Goodpasture, if patient young adult male, okay, usually it is 35, 40-year-old man has hematuria and hemoptysis. That is classical symptom, and you should know that in both, when you find here comes complex cases where you need to make differential diagnosis from vasculitis and Goodpasture syndrome. In both cases, you have autoimmune condition. They are right, autoimmune systemic condition. And imagine you have young patient who has hematuria and hemoptysis. And under microscope, what you see in the kidney, you will see linear immunofluorescence, okay, linear immunofluorescence. But how can you differentiate that it is Goodpasture syndrome or Wegener's granulomatosis, for example? Okay, that is important. But because clinically, Goodpasture syndrome and Wegener's granulomatosis usually are similar. Okay, with this, that glomerular and alveolar damage you find there in both of them. Okay, at first sign, when you have this patient, you need to distinguish which systemic condition it is and what are you looking at in this case. Clinically, if it is Wegener granulomatosis, what are you expecting? How can you differentiate Wegener's from any other vasculitis and systemic condition? Do you remember? Sinusitis, guys, do you remember? Sinusitis, Wegener's granulomatosis, that is super high yield. And please memorize, if patient has history of sinus involvement in the past, you can be sure that it won't be Goodpasture syndrome and it will be Wegener's granulomatosis. And why it is important, guys, treatment is so different. And if you don't start treatment on time, patient will die. Okay, it progresses quite fast. For that reason, you look at the sinusitis, okay, sinusitis, And also, guys, you look at what? For example, do you remember in the beginning I mentioned about negative immunofluorescence? In vaginal granulomatosis, you will have negative immunofluorescence. Post-immune will be, but you should find what? Cyanca, right? That I wanted to talk about good posture syndrome because of differential diagnosis that is really high yield. So rapidly progressive glomerulonephritis, I'm talking now. Rapidly progressive glomerulonephritis is complication of many systemic conditions. That's why you need to discuss all these conditions that we can progress with this rapidly progressive glomerulonephritis. So one is good posture syndrome, where you find linear immunofluorescence. Then you find, guys, granular immunofluorescence. So which diseases can progress to rapidly progressive glomerulonephritis? One is where you have linear, and another is where you have granular immunofluorescence. And the granular immunofluorescence is which one? Post-streptococcal glomerulonephritis. We discussed it. Do you remember? We talked about post-streptococcal glomerulonephritis, and it was immune complex disease, and there we found this granular immunofluorescence. And also here comes diffuse proliferative glomerulonephritis. Diffuse proliferative glomerulonephritis is disease where you find this granular pattern, okay, granular pattern. And here comes, I want to talk about lupus here, okay, lupus. Diffuse glomerulonephritis is you find, sorry guys, I'm talking to lupus now, okay? Lupus, I will talk about it later as well, but now I will mention that when you are talking about lupus, in the beginning you have nephritic syndrome, but don't get confused, because in lupus you can find nephrotic syndrome as well. And if your patient has lupus and you have hematuria and nephritic syndrome, that will be diffuse proliferative glomerulonephritis. And if it is nephrotic syndrome, okay, if it is nephrotic at later stages, for example, it will be membranous nephropathy. Okay, these two conditions are related to lupus. Just keep in mind here, and later I will revise again. And we should know that in lupus, guys, you should find granular immunofluorescence, okay? And I mentioned already negative immunofluorescence. Negative means post-immune. Post-immune, guys, means negative. Please, all of you, memorize it. And in post-immune, when you see biopsy material and you don't see any immunofluorescence and you have kidney damage, you need to check serum for other antibodies, okay? That is really high yield for management. And what are you going to see? You are looking for this MPO and PR, right? Do you remember this ANCA and PANCA and CANCA has different names? And you should know differential diagnosis. Without knowing this, you won't be able to make differential diagnosis, because we have some diseases that are positive for PANCA, and we have some diseases that are negative for PANCA and is positive for CANCA, right? CANCA and PANCA diseases you need to memorize. That is really high yield. What is difference between them? You know from this vasculitis, okay? Vaginous granulomatosis, I showed you this image here, guys, this one. All this good posture, diffuse proliferative glomerulonephritis, post-streptococcal in adults can lead to RPGN. So we were talking about RPGN, and then I discussed all these conditions, okay? Differential diagnosis, you need to remember, because you have a patient, you made diagnosis of RPGN. How? You found crescents, okay? Okay, then you need to know what is etiology, what do I need to treat? And then you need to know how to differentiate all these disorders, okay? So good posture is linear the deposition, here is granular deposition, and they are post-immune. Okay, you understand logic, what I followed? Don't get confused. that is what I wanted to discuss. Vaginal granulomatosis, you need to differentiate from the good pasture because these two has similar clinical picture. And you need to know that in vaginous, in clinical history, you have sinus involvement that is really high yield. And also next thing is, here is linear immunofluorescence, at least immunofluorescence positive, and here is negative. But you have in vaginous CNK positive. Vaginal, you remember the pneumonic from vasculitis. And microscopic polyangiitis and Church-Strauss are also important to differentiate because both of them are positive for PNK, right? PNK, perinuclear anti-neutrophilic antibody. CNK and PNK, I will just repeat it again here for others, that P-ANCA is perinuclear and C-ANCA is cytoplasmic, and ANCA is anti-neutrophilic cytoplasmic antibody. So we differentiate them based on location. And in vaginal, this is cytoplasmic, dispersed throughout the cytoplasm, you will see this antibody. And in microscopic polyangiitis and Church-Strauss, you will see only perinuclear deposition, okay? So you have two diseases with PNK. Then how are you going to differentiate microscopic polyangiitis from Church-Strauss? Here comes three important things. You remember eosinophilia, asthma, and granulomatous inflammation, right? Church-Strauss. In Church-Strauss, you find granulomatous inflammation, which you don't find in microscopic polyangiitis. Number two, you have eosinophilia. You find only in Church-Strauss. So eosinophilia, wherever you found, this is Church-Strauss vasculitis, and asthma also. Asthma you also find in Church-Strauss, and you should not find in any other vasculitis. Okay, they are PNK. So that is really important when we are talking about rapidly progressive glomerulonephritis. Now, next one, guys, is immunoglobulin A nephropathy. Immunoglobulin A nephropathy, guys, is you should find in kids. Okay, in adults you should you usually don't find it. And what it is? Mucosal aid, this is important. Seen in kids after mucosal infection. Usually a kid eats some burger or something, okay, so infection, stomach ache a child had, and after some time they have this immunoglobulin A nephropathy, okay. Most common nephropathy worldwide. It is, and you don't, it is not severe condition, by the way, okay. And why? The immune complexes, you have there immune complexes, but it is immunoglobulin A complex, okay? That is important here, pay attention. Immunoglobulin A nephropathy, common cause of nephropathy worldwide, and I will give you some hint now what you need to know when we are talking about this glomerulonephritis. Epidemiological data, how important is in pathology, you know, right? And for doctors, it is important. So when you have a question, what is the most common nephropathy worldwide? It is immunoglobulin A. You will have a question, what is the most common nephropathy in Caucasian population, and what most common nephropathy in Hispanics, for example, and African American. And you should know they mentioned some diseases. Hispanic, for example, you have the focal segmental in Caucasians, usually diffuse proliferative disorders. In Georgia, for example, diffuse membranopathy you will find most commonly. That is in general overview I'm saying, but when you discuss separate disorders, you should pay attention. So immunoglobulin A nephropathy, most common worldwide, all right? And you find it in kids. And what is it? Pathogenesis. Pathogenesis, what says itself? Immunoglobulin A nephropathy. Do you remember which pathology it is, which vasculitis it is related? Anyone remembers vasculitis? Berger disease, do you remember? This another name is Berger disease here. It is related to immunoglobulin A vasculitis. Do you remember vasculitis? These two are linked actually, okay? This vasculitis also is related to this mucosal infection. So mesenchyme, where? Location is important. Where you have this immunoglobulin A immune complex deposits in the mesangium of the glomeruli. That is really high yield, okay? Location memorized in the mesangium. Also, we are talking about nephritic syndrome. It is hypercellular inflammation is there. Immunoglobulin A, you have overproduction of immunoglobulin A. Why? Because the child has this infection, ate something, for example, and this irritation of the mucosa, okay, mucosal infection, produce excess immunoglobulin A. And as you have this immunoglobulin A, excess production of immunoglobulin A, it deposits in the kidney, okay? There is not anything really dangerous, okay? Tons of immunoglobulin A you have, and it goes into the mesangium and it deposits as an immune complex within the mesangium. And it's going to result in glomerular bleeding. You understand, right? This complex will damage these blood vessels finally, and it will lead to glomerular bleeding. For that reason, hematuria you need to have. It is, guys, it resolves itself, okay? Usually it resolves itself, but if you have it is episodic. What is the meaning of episodic? Episodic means you have infection, and as this infection, mucosal infection, is resolved, that means this inflammation in the kidney will go away itself, okay? But if you have a repeated infection, for example, repeated infection, then it will lead to damage of the glomeruli, okay? That is another episode, repeated episodes of bleeding from the kidney. If you have, it can lead to renal failure, of course. So you need to be really careful with the mucosal infection in children. Okay, so here is nephritic syndrome, guys. Again, you have deposition of immunoglobulin A immune complexes in mesangium, and what you have? Hematuria with red blood cell count. That is keyword here. Hematuria with red blood cell count. You must find this. And immunoglobulin A will be increased as well. And the last disorder that we saw, guys, just immunoglobulin A. It is related to Berger disease. And the last one, nephritic syndrome, when I'm talking about, here comes one inherited disorder. Okay, inherited is Alport syndrome. And why it is clinical classification I follow now. And clinically, we are talking about nephritic syndrome. And here comes one inherited disorder, inherited glomerulopathy, and that is Alport syndrome. And what is Alport syndrome? Alport syndrome is inherited defect of type 4 collagen. And what it means, type 4 collagen you find in basement membrane, right? In basement membrane. So what happens here is you get thinning and splitting of the glomerular basement membrane, okay? Thinning and splitting. And for that reason, as you have this splitting and thinning of basement membrane, it's going to result in isolated hematuria. Okay, so hematuria you will have, and you know that where you find hematuria, if you find hematuria, that is nephritic syndrome. Okay, nephritic syndrome, but you cannot make diagnosis Alport syndrome based on hematuria only. You must have hearing loss. Okay, hearing loss because you have basement membrane damage in this region, ocular disturbances. Okay, because imagine, guys, you have problem with basement membrane. For that reason, wherever you have this basement membrane, you will have problem. So hearing loss and ocular disturbances is very high yield here. If a patient also has hematuria, okay, isolated hematuria, and also family history, it is genetic, right? It is X-linked disorder. Alport syndrome is X-linked disorder. You will have, you can make diagnosis of Alport syndrome. So it was about all about nephritic syndrome, guys. And what is important here? Nephritic is inflammation. Clinical manifestation is so important to know. Rapidly progressive glomerulonephritis. First streptococcal glomerulonephritis, immunoglobulin A, Alport syndrome, and all these conditions that can lead to rapidly progressive glomerulonephritis. So rapidly progressive glomerulonephritis we discussed in nephritic syndrome, okay, as well as in nephrotic as well. And why we mention it there. Here comes very important is to know pathogenesis, to know hematoxylinosin, immunofluorescence, and EM features. EM features we did not mention much, but immunofluorescence we mentioned. And why? Immunofluorescence, we had 3 types. I mentioned, right? Theta linear, granular, and negative. Negative you find in this disorder, granular you find in post-streptococcal glomerulonephritis, and diffuse proliferative glomerulonephritis. Diffuse glomerulonephritis we will find in nephrotic. I will talk about it. And good posture. This image is very good as well. Post-immune. You see minimal deposits. Minimal deposits means under the microscope you won't mention it, but you should find ANCA, okay? ANCA, PANCA, but in most cases, 80% ANCA is positive, but you can find in post-immune glomerulonephritis where ANCA will be negative as well. So it is rare cases, guys, don't worry about it. Immune complexes can be caused with where complement is decreased, and where the complement you don't have. For example, this is immunoglobulin A we mentioned, okay, and anti-GBM. This is anti-GBM, anti-GBM, where you find that is linear, okay, linear, where you find that means you have antibodies against basement membrane. And one example here is good question, okay? But overlap is here. You know, guys, most complicated thing in medicine, many complicated stuff we have, but one of the most complicated thing is to make diagnosis of glomerulonephritis, okay? Because you will find many overlaps here. So you need to know really, really well what is high yield and details. For differential diagnosis, knowing details is very important. Okay, that was as a hump, you know, immune complex deposition. In post-streptococcal glomerulonephritis, there are from colon disorders. And nephrotic syndrome is next. Give me 10 minutes, guys, and I will come back in 10 minutes and continue with nephrotic syndrome. Thank you. So guys, I'm back, and before we start with nephrotic syndrome, just make this difference between them, okay? Nephrotic vs nephrotic vs nephritic proteinuria. You see, mild, moderate, and severe. Mild to moderate to severe, you find proteinuria. You see in both, you find proteinuria. And in the beginning, I mentioned this. Don't get confused. If you find proteinuria in both cases, always pay attention amount, okay? More than 150 and less than mg, and more than 3.5 should be if it is nephrotic, and it range usually, okay? You can have mild to moderate. Mild proteinuria you don't have because you have damage of the glomeruli. So moderate proteinuria you always have, but again it is always less than 3.5 gram per day. Hypoalbuminemia you should not find in nephritic syndrome. We did not mention hypoalbuminemia, but you lose albumin in nephrotic syndrome. Edema, just pay attention to the edema. You see it ranges here, but you have moderate edema, and you can have generalized edema. It depends to the stage, guys, okay? Hematuria. Hematuria you must not have in nephrotic syndrome, and I will talk about it why. Nephrotic hematuria, blood you should not find in the nephrotic syndrome. Oliguria you find here, but you should not find in nephrotic syndrome. Okay, that is important. Hyperlipidemia. Hyperlipidemia is important how we differentiate nephrotic to nephritic, because you have no here. Lipiduria, we mentioned about it, I will mention as well. And hypertension, you see, water and salt retention you have in nephritic syndrome, but you don't have in nephrotic syndrome. So that is just to differentiate, okay? But what confuses students is actually proteinuria and hematuria. We always give students this clue that remember that hematuria you have in nephritic syndrome and proteinuria you have in nephrotic syndrome. But what if you have proteinuria and nephritic as well? So here important is amount. And as for hematuria you should not have in nephrotic syndrome, okay? That is. Now, nephrotic syndrome definition, that is glomerular injury is due to cytokines, not neutrophils. That is high yield, okay? Neutrophils was important in nephritic, and here comes cytokine. Why cytokines are important, guys? I mentioned that T cell mediated in pathogenesis. Do you remember we mentioned T cell mediated cytokines? Cytokines, what does? Cytokines hit the podocyte, okay? Hit the podocyte, and that's why it leads to damage of the glomeruli. And as you don't have the podocyte, you have filtration. You lose a lot of proteins, okay? So cytokine damage podocytes, causing them fuse together, and cytokines destroy the negative charge of the GBM. That's why it affects filtration. Clinical laboratory finding, again, always please memorize 3.5, okay, that is must. Generalized pitting edema and ascites due to hypoalbuminemia. Hypoalbuminemia is keyword here, because what does albumin? Albumin actually regulate oncotic pressure, okay? And as you don't have this plasma oncotic pressure, decrease, a lot of fluid goes to the tissue, okay? And finally, it will lead to pitting edema, and you have increased risk for developing spontaneous peritonitis due to Streptococcus pneumonia, guys. It is complication, okay? It is complication. In rare case, usually it lead to death, but in modern world we can manage such situations. Hypertension in some types due to sodium retention. Do you remember I showed you this picture? Hypertension you should not find in nephrotic, but in some cases you can have hypertension as well, okay? Hypercoagulable state. Hypercoagulable state is important, guys. And why hypercoagulable state? coagulation is increased because as you have nephrotic syndrome, these patients usually lose antithrombin 3, and finally it will lead to potential for renal vein thrombosis. Renal vein thrombosis, guys, is complication, and if you have a question about complication in clinical case, you should know mechanism. Okay, you should know mechanism, and if you know this mechanism, it is very easy. Lipids, I mentioned hypercholesterolemia. I mentioned that is cholesterol is increased. So lipiduria you can have. Hypoalbuminemia increases synthesis of cholesterol, that you understand. And this is important. Hypogammaglobulinemia. In clinical cases, usually people with nephrotic syndrome has infections. Okay, in fact, they are prone to develop multiple infections. And why? Because they have hypogammaglobulinemia, immunoglobulin they don't have. For that reason, they have increased risk of infections. Okay, and fatty cast because of this hypercholesterolemia. That is very important. Okay, primary nephrotic types of glomerular disease. Diseases are here. Minimal change disease, focal segmental glomerulosclerosis, diffuse membranous and membranous, and type 1 membranoproliferative disorders, and type 2. I will go through this. These actually are very well explained in pathoma, so I will follow the pathoma now. There's pictures and systemic disorder, that is diabetes. Okay. So what happens actually here? This is I forgot this slide to put, so I will stay here. So guys, when we are talking about nephrotic syndrome, again, what you need to pay attention. Please always in clinical case look at the protein level they lose daily. Here also one thing is important. Hypercoagulable state, yes, because you will find patient who had this renal vein thrombosis and Budd-Chiari syndrome as well, and patient has hypercoagulable state and had pitting edema as well, and you can relate them together, and you should know that the patient has nephrotic syndrome. But then question might be, what is the cause of this nephrotic syndrome? And here comes this information, but it tests your knowledge if you can differentiate these different disorders. Okay, hypercoagulable state is very important. Gamma globulin is infection. If we have patient with infection, that is also important. And what else cases? Hypercholesterolemia I mentioned, and I don't want to forget anything. Anyway, this oncotic pressure you understand, so that is general symptoms. And first disorder, what you need to understand here is minimal change disease, impaired. 6 major disorders you can memorize, 6. 2, 2, 2, like this in pairs. Minimal change disease, focal segmental glomerulosclerosis, these two together. Then in between membranous and membranoproliferative, and you remember, you hear membrane, right? Membranous. And in general, in the beginning, I mentioned general principles, right? Terminology. Terminology is confusing here, and that's why I started with terminology. And then last 2 is related to systemic disorders. Okay, I will start with women and minimal change disease. Here comes, guys, child is important here. And you remember, in children, we find nephrotic and nephritic. If it is nephritic in children, most commonly will be post-streptococcal glomerulonephritis, and if it is nephrotic, it will be minimal change disease. And word says itself, minimal change disease. Minimal change means you cannot observe anything under microscope. It is like myocardial infarction. Do you remember? Within 2 hours under microscope, you cannot find anything. It is like this. You have changes, a function change, but under microscope you cannot see anything. But how you can observe something, any change? To make diagnosis of minimal change disease, you need to use EM, electron microscopy, because without electron microscopy, you cannot observe anything. So children, here is patient is child, and pay attention. Is it nephrotic syndrome or clinical manifestation? You can read, is it nephrotic or nephritic? And then if the patient has protein loss, it will be minimal change disease. It is very, very guys, easily treatable, okay? Easily treatable. It does not cause any severe changes, but it can progress, okay? If you don't treat still, it has very good response to steroids, very good response in children. But if it doesn't respond well, it will progress to focal segmental. But now I'm talking about minimal change disease. What is important? All nephrotic disorders, nephrotic syndrome pathologies, guys, are idiopathic. Okay, idiopathic. That means we don't know etiology. You remember in nephritic syndrome, we knew reasons, like here there was streptococcal infection, there was for example, the vasculitis, immune complexes, we knew that, but here most of them are idiopathic. But in some cases, we know the reason. And here, minimal change disease, you can find, for example, in the beginning I mentioned Hodgkin lymphoma. Do you remember? Because it is related to cytokines. Cytokines is the pathogenesis here. Cytokine lead to damage of the podocyte. Okay, and for that reason, in Hodgkin lymphoma, guys, you have these red chamber cells. They produce a massive amount of these cytokines. And these cytokines, how do you know you have a lot of cytokines? It gives clinical picture. What clinical picture it is? Fever, chills, night sweats. In Hodgkin lymphoma, you find it. And as you have overproduction of cytokines, they knock down podocytes, okay, and will result in minimal change disease. And in Hodgkin lymphoma, do you remember we have two peaks, dichotomous distribution. It has one is in children and teenagers, okay, like 12, 13, 15, 18, this age. And the second peak we find in older patients, like 50, 60. Here in the children, you can have this minimal change disease, okay, as a complication. This happens in case of not idiopathic, okay? Idiopathic means we don't know. We don't know anything but the reason. And in case of Hodgkin lymphoma, you can have minimal change disease. Now, it is very interesting disorder, very interesting. Actually, clinically, what you see, child, you have proteinuria, you will find. Okay, but you take biopsy and you cannot find anything. Absolutely normal glomeruli, you will see there, absolutely normal. On hematoxylin ozone, so change is so minimal, it is not manifested under the microscope. But you see, what you see, you find a little bit lipid, okay, within the proximal tubular cells. That is what you see. You might find it sometimes on hematoxylin. And key finding, how you make diagnosis, as I mentioned already, it is EM, electron microscopy. And what you see under the electron microscopy is effacement of the food processes. Food processes, you know, these layers, anatomy, do you remember? Here, this remember, right? Actually, here comes this podocyte, okay? And food processes, you see here food processes. These are attachments you should have. Fusion of the food processes you should have there. And what happens actually is filtration increase, okay? You lose protein in that case. And but it is so minimal, again, it is so minimal change clinically. Clinically, you have manifestation, but morphologically, you don't have any manifestation. And immunofluorescence, guys, what do you think? Immunofluorescence in this case, in nephrotic syndrome, especially focal segmental, and in minimal change disease and focal segmental, you don't have any immune complexes, okay, and you don't have any antibodies. There is not inflammation. There is not inflammation. For that reason, IF will be negative. So you take biopsy, and their IF will be negative. Nothing you will find there at all. Hematoxylin eosin is normal. Morphologically, you don't find any changes. Also, you can think, and you have child as a patient, you can think that it is minimal change disease. And how you make diagnosis? This is the disease of exclusion, guys. You need to exclude all other causes, and what is left will be minimal change disease. Okay, if you don't have chance to do EM, because EM, electron microscopic examination, usually helps you to make this diagnosis. And clinically, important thing, what you need to pay attention in minimal change disease is you get selected proteinuria, guys. Selected proteinuria, that is important. And you do lose, this means that you do lose albumin, but you do not lose immunoglobulin. Okay, immunoglobulin, you don't, albumin, you just lose. Okay, that is sign of minimal change disease. Word says everything. IF is negative, hematoxylin as in negative, EM only positive. And you should know that what you see on the EM, you see effacement of the food processes. So these podocytes are affected because of cytokine overload, let's say, and you have damage of the podocytes. Okay, it has again, I will repeat, it has very good response to steroids. But if something happens, that it does not, for example, respond well to steroids, what will happen is you will have focal segmental glomerulosclerosis. So that is, imagine that focal segmental glomerulosclerosis will be next stage. Okay, in the beginning you have minimal change disease, and it can progress to focal segmental glomerulosclerosis. Again, here comes terminology, and in the beginning I mentioned what is focal and what is segmental. Focal, do you remember, it was less than 50%. You remember that, right? Less than 50% of glomeruli. So only part of the glomeruli are affected. But segmental means only small portion of the glomeruli itself is affected. And sclerosis means you don't have here a crescent, but you have collagen. So under microscope, you see pink appearance, like here is picture. No. For example, this one. Okay, this is pink. Everything is pink here, but you see this one. This is pink, for example, and just small segment is affected. Okay, focal segmental glomerulosclerosis in only part of the segment glomeruli. You find this one. Now, what happens? What it means? Actually, focal segmental glomerulosclerosis, guys, again, like minimal change disease, idiopathic. We don't know reason. Most commonly, if you find this disease, you will never know where it comes from, but association helps us. Association. You should find it in patients with HIV, heroin addicted people, and sickle cell disease. So sickle cell anemia, do you remember, in sickle cell disease people, you can find, there was mentioned actually this complication. Sickle cell disease, people can have this focal segmental glomerulosclerosis. Now, HIV, sickle cell, and heroin, you need to pay attention. Guys, focal segmental glomerulosclerosis, when we talk about it, question will be, I see here, always pink deposition of collagen. What you see there is deposition of collagen in glomeruli, okay? That is, segmental means only in small portion, and focal means only some of the glomeruli are affected, okay? So what you see under hematoxylin eosin, you should see pink sclerosis within the glomeruli, okay? Pink sclerosis, only small portion, that helps you. What you will see under EM, guys, under electron microscope, what are you going to see? It is complication of next stage. You can remember like this. It can be next stage of minimal change disease. So what are you going to see under EM? It will be effacement of processes, right? We don't need definitely to have minimal change disease, okay, in clinical history. You don't have to. You can have focal segmental glomerulosclerosis, but it helps you to memorize, okay, easily. Memorize and understand the logic. So if in minimal change disease, only thing you observe is effacement of processes, okay, use of the podocytes, then you also are expecting to find this effacement of processes in focal segmental glomerulosclerosis. But in addition to the effacement of food processes, you should have this collagen deposition as well, right? For collagen deposition. That is focal segmental glomerulosclerosis. Progression, guys, we talked about it. What you will see under immunofluorescence microscope? Nothing. It will be negative as well because there is no immune complex is nothing. Just you will find cytokine there, okay? And compared to minimal change disease, focal segmental glomerulosclerosis does not respond steroids well, okay? It does not. So it usually can progress to chronic renal failure. Okay, so focal segmental glomerulosclerosis is quite bad disease. All right. So how you make diagnosis? Biopsy. Always remember three things: hematoxylinosin, EM, IF, immunofluorescence. Under the hematoxylinosin, you should see sclerosis. Okay, segmental sclerosis in some glomeruli. You should find also on EM, phase effacement of this podocyte, and immunofluorescence will be negative. Okay, that's important. In adult patients, you find this. Unlike minimal change disease, most commonly you find in children. And treatment is important. As minimal change disease responds very well to steroids. Complete recovery you will have, but if it is some case that it does not respond, it can progress to the focal segmental glomerulosclerosis. That is two conditions of nephrotic syndrome. Clinical picture, what will be nephrotic syndrome? That means proteinuria definitely is there, but do you remember we mentioned in minimal change disease, there was selected proteinuria, right? You lose albumin, but not gamma globulin. Well, immunoglobulin you don't lose. That is also important. Next two condition, guys. Next two condition in nephrotic syndrome. This is complex topic. Please listen and read carefully and emphasize this part, okay? Because in glomerulonephritis, this is most complex topic actually. Why? We have type 1, type 2, and there are many details and you need to memorize them. But what is it? This is membranous nephropathy and membranoproliferative glomerulonephritis. You remember in the beginning, we mentioned about membranous, right? Membranous, wherever you hear membranous, that means it crescent means you have this fibrin and macrophages. Membranous means you have thickening of the wall, and granular means, and linear, what means, you remember that. I will send this presentation, you will say, but membranous, wherever you see and hear, that refers to the basement membrane, and it means thickening, okay? Thickening of the wall, of the, not wall, but basement membrane. And if you have thickening of the basement membrane, we mentioned what can cause this thickening. The thickening can be caused by immune complexes. So here comes immune complexes already, and immunofluorescence here will be positive. Okay, and here very, very important actually how we make diagnosis of this part, this nephrotic syndrome, is And the immune fluorescence microscope helps us, okay? And here you should know, is it subendothelial, subepithelial, or basement membrane deposition, or mesangial deposition? Here comes this knowledge you should know definitely, and that is how we make differential diagnosis. Anyway, you understand that membranous nephropathy is about basement membrane, okay? And also, guys, epidemiology. I want to repeat again. Most common cause of nephrotic syndrome in Caucasian adults. Okay, in Georgia, most commonly you will find, for example, I've seen many patients with this membranous nephropathy. Okay, this is also a very bad condition, and chemotherapy is needed here as well. And what else is important? Idiopathic it is. Membranous nephropathy and membranoproliferative nephropathy. Membranoproliferative, you remember, right? We mentioned it as well. Both are related to immune complexes. Idiopathic means we don't know what is the reason, but association comes here as well. You remember hematoxylinogen, heroin, and drugs, heroin and sickle cell was in segmental. And here association hepatitis B or C, solid tumors, lupus, and drugs. These associations are very high yield. Please pay attention to this information, okay? This is really important. Hepatitis B, C, tumors, lupus, and drugs. This information will help you to solve many complex cases, okay? Hepatitis B, very, very interesting disease. You remember it is related to polyarteritis nodosa. Polyarteritis nodosa. It is associated with this as well. But membranous nephropathy, when we are talking about it, again, this is related to nephrotic syndrome, okay? And nephritic, another the name, the proliferative, membranoproliferative glomerulonephritis. Do you remember? It was related to nephritic syndrome. In both cases, you see, we have two conditions, membranous and diffuse proliferative glomerulonephritis. One characterized with nephritic syndrome and another with nephrotic syndrome, but both in pathogenesis has one reason, immune complex diseases they are, okay? So you have immune complex condition that can lead to nephrotic or nephritic syndrome, and which disorders they are, you should know. Now I'm talking about nephritic syndrome. The nephritic syndrome we discussed, this is diffuse proliferative glomerulonephritis and nephrotic syndrome. You remember lupus, association lupus. Systemic lupus erythematosus is systemic disorder. Systemic disorder, it affects multiple organs, and one of the organs that is affected is kidney, and cause of death actually is kidney failure, okay? And what happens? It begins if you have a lupus and patient has nephritic syndrome, for example, hematuria, pitting edema, hypertension, and stuff. Most likely, it will be diffuse proliferative glomerulonephritis. And if the patient has nephrotic syndrome in lupus, it will be membranous nephropathy. Okay, membranous nephropathy that is really, really high yield. In both cases, guys, membrane is affected. Basement membrane is affected because of immune complexes. All right, thickening of the membrane is high yield. Now, here comes already knowledge about immune complexes, and immune complex is very, very important. What type of immunofluorescence are you going to see here? What we mentioned. If you have immune complex disease, immunofluorescence will be what? Granular or linear? What will be? Granular or linear? If you're here, guys. If it is immune complexes are always granular, okay? Grainy immune grains, it looks like grains. The immunofluorescence you will have there, okay? Yes, immune complex deposition at the level of the podocytes you will have there, okay? This immune complex deposition you have at the level of podocytes. So you will have underneath what? Epithelium or endothelium. Epithelium, of course, because at the level of podocyte, if you have the position of the complex, that will be subepithelial, okay? So granular deposition, it is, first of all, guys, membranous nephrotic, I will start again and repeat in order. Nephrotic syndrome I'm talking about, and this is membranous nephropathy. Membranous nephropathy, you know already that membrane VIY here, that means thickening of the basement membrane. As it becomes thick, that means I have immune complexes. Then comes already, I should know what type of immune complex deposition I have, what type of immunofluorescence I have. This is granular, and deposition is subepithelial because deposition happens at the level of podocyte. That is one thing. Then I also mentioned that membranous nephropathy you find in different diseases. Here, this association is highlighted because each of them can discuss separately: hepatitis B, C, lupus, tumor, and drugs. And I talked about lupus. In lupus, both you can have nephritic and nephrotic. If it is nephritic, it will be membrane proliferative, and if it is nephrotic, it will be membranous, right? It is over. Now, hematoxylin, again, what are you going to see, to find? Podocytes will be damaged on hematoxylinosin. Always, here, immunofluorescence is more important than hematoxylinosin, okay? Immunofluorescence always helps here to make diagnosis. Actually, all of three you should have: hematoxylinosin, immunofluorescence, and EM. So all three information is important. Immunofluorescence, you should find subepithelial immune complexes, granular immunofluorescence, and what you see under EM, okay? EM, that is electron microscopy. Guys, you have damage of the podocytes, right? Here is important that underneath the epithelial cells, you have these immune complexes. So imagine you have podocyte, and under the podocyte, you have deposition of the immune complexes. What it will do? It will remove these podocytes, right? It fall off from this area, this podocyte. And how this podocyte will respond? This podocyte will respond by trying to lay down additional basement membranes. That's why it becomes thick, okay? And imagine now that what happens under the microscope, under the EM, electron microscope, here comes spike and dome appearance, okay? Here comes, this is important to memorize, spike and dome appearance. And what is this spike and dome? It is not difficult. You don't have to just memorize it. If you understand, it is very logical. And what happens? Imagine you have immune complexes which accumulate under the epithelial cells, and you have thickening of the basement membrane. And then what happens is actually lay down the additional basement membrane, right? And what's going to happen is you have a deposition of basement membrane as domes, okay? Dome, you understand, like these hills you find on the basement membrane. And between these two domes, you have spikes, right? Between the two domes, you have spike between them. And for that reason, as you have these multiple areas of this how can I show? Here is not, I imagine this is basement membrane, right? And you have here is epithelium. And as you have deposition of these immune complexes, here is one spike, here is another dome, here is another dome, here is another dome, and between them this is spike, guys. So in this case, in membranous nephropathy under electron microscopy, you will find this spike and dome appearance. Okay, that means spike and dome. Different domes you have under the epithelial cells. And finally, what you see, that is spike and dome appearance. Nothing complicated here. Okay, so granular immunofluorescence, you remember, subepithelial deposition, and spike and dome appearance, okay? Spike and dome appearance on membranous nephropathy. Membranous nephropathy is also related to lupus. You remember it. Okay, you understand. Next one, guys, is membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis is disease in first state, for example, guys, you will find diseases that is characterized with nephrotic syndrome and nephritic syndrome. But two conditions you have where you have both nephrotic and nephritic, okay? We have such conditions. For example, and one of these membrane proliferative glomerulonephritis is one of them, okay? Diffuse type. And what you need to know in membranoproliferative glomerulonephritis, membrano, you hear, right? Membrano. So what it means, you definitely have thickening of the capillary membrane. That is what you see under hematoxylin morphology. What is morphological sign of membranoproliferative glomerulonephritis or membranous nephropathy? If I ask, you can say that you have thickening. You see thickening of capillary basement membrane. Okay, that is what you see in both cases. But unlike compared to the membranous nephropathy, in membranoproliferative glomerulonephritis, what you see? In addition, you should, immune complexes are in both, but in addition, in membranoproliferative glomerulonephritis, what are you expecting? Proliferation, guys, proliferation. And what proliferate here? That is important. In membranoproliferative glomerulonephritis, what proliferates is mesangial cells, okay? Mesangial cells. Here, you should not find neutrophils, okay? We don't find here neutrophils. We find mesangial cell proliferation, okay? And what does it? Under electron microscopy, you have tram track appearance. Tram track, you know, tram, and you know it's track. And you two lines you have that is connected with the short lines of the tram track, you know how it looks. And literally you see something like tram track appearance. And where this tram track appearance come from now? You know that you have proliferation of mesangial cells, and you also know that you have immune complex deposits, right? So in membranoproliferative glomerulonephritis, you have immune complex deposit. And as you have this deposit, and you have this proliferation of these mesangial cells, and mesangial cells have these cytoplasms, right? They grow and proliferate. Actually, they go through this deposit, okay? Go through in the middle of the deposit, and separate the deposit into two pieces. And as it separates these two pieces, it gives appearance of tram track. That's all, okay? So if you wonder why do they have this pike and dome appearance, hump, subepithelial hump, how we mentioned this tram track, they have all explanation, okay? It is very logical. You have mass of this deposit, immune complex deposits, and you have proliferation. It is membranoproliferative glomerulonephritis. You have proliferation of mesangial cells, and as it goes through in the middle of the deposit, it gives this split, this deposit, and gives appearance of tram track. Okay, so that is very, very easy. Now, when we are talking about membranoproliferative disorders, guys, here comes lovely, complicated thing. That is type 1 and type 2. That is what you need to pay attention, okay? Type 1 and type 2 is very important. Diffuse membranous glomerulopathy in nephrotic syndrome you will find, but please make sure that don't get confused that diffuse membranous glomerulopathy you will find in nephritic as well, okay? Both you can find there. So now I'm talking about membranoproliferative glomerulonephritis, where we need to pay attention to type 1 and type 2. And it's important how we make difference between them. So two types, and type 1 is location, guys. We differentiate based on location. Type 1, membranoproliferative glomerulonephritis, is you have IC deposits underneath the endothelial cells, okay? Subendothelial, guys. You remember, we have basement membrane, we have endothelium, and we have podocytes, epithelium. So depending on where you have deposition in the basement membrane, subepithelial deposition or subendothelial deposition, we have different types. Okay, so type 1 is subendothelial. Okay, and where you find it, do you remember in the beginning I mentioned about association, which is really high yield hepatitis virus B, C, lupus. I talked about drugs and what else? Tumors, right? So type 1 membranoproliferative glomerulonephritis you find in hepatitis B and hepatitis C virus infections, okay? Because in this case you find subendothelial deposits. So type 1, so imagine now you have clinical case, patient with hepatitis B or C, and they have nephrotic syndrome, and give all these clinical signs and symptoms, and you need to differentiate what type of membranoproliferative glomerulonephritis is there, type 1 or type 2. And you know that if there is subendothelial deposition, it will be, and as the patient is type hepatitis virus, you know already that type 1 you find. And what means type 1? It means subendothelial deposition, okay? And this type more often is associated with which pattern on electron microscopy? Tram tracks, okay? Tram tracks. So tram tracks, you know already what means. Tram track, wherever you hear, that means proliferation of mesangial cells. And you know you have deposition, mesangial cells going through in the middle of the deposition, and it split this deposit into two parts. So it gives appearance of tram track. So that is type 1, association with hepatitis B and C. Now type 2, membranoproliferative glomerulonephritis, you get deposition within the basement membrane, guys. Okay, please, you can make note. Subendothelial is in type 1 and basement membrane is in type 2. Okay, and association here is important. In infections, you find it, and actually, what is mechanism? Pathogenesis of type 2 membranoproliferative glomerulonephritis is important. One thing you remember that there is membrane immune complexes you find within the basement membrane, that is type 2. But pathogenesis is important, and what is it? We have nephritic factor, rheumatoid factor. Do you remember, guys, in other condition, for example, in rheumatic fever, these factors we have, right? And nephritic factor we have in nephrotic syndrome, for example. And this nephritic factor in glomerulonephritis is C3, okay? C3 complement it is. And now what happens, guys? This nephritic factor, C3 nephritic factor, is molecule which stabilizes C3 convertase. C3 convertase. Maybe you remember this metabolism of the function of the complement, how it functions. We have one enzyme, very important, C3 convertase. And C3 convertase is very labile in normal condition. It should degrade immediately, okay? It should not be stabilized because what is the function of C3? It converts complement the C3A and C3B, okay? It's converts to C3A, C3B. And if it does not degrade, whenever you have C3 convertase formed, if it does not degrade, it will amplify inflammatory reaction. Okay, it will activate inflammatory reaction, and inflammation is not good. But what happens actually in this type 2 membranoproliferative glomerulonephritis pathogenesis I'm saying now? You have nephritic factor, which is C3, and function of this nephritic factor is to stabilize C3 convertase. And you know what is function of C3 convertase, right? And as you have the stabilization, it does not block activity. That is important. Don't say that it blocks activity. It does not block activity of the C3, but it stabilizes it, so it cannot break down. C3 you have. It keeps C3 convertase there on the stage, and it amplifies this inflammation, okay? It results to inflammatory damage to the glomeruli. And why it happens actually, you know that you can blame this nephritic factor that is C3, okay? Function, what is the function of C3? That stabilizes this C3 convertase. Actually, guys, you know now, the overactivation of complement with decreased G3, you will have finally, if you have this rich convertase, you have overactivation of complement, and finally it will decrease to T3. And more important point here is, you remember, membranoproliferative glomerulonephritis, I mentioned already, but I repeat again, it can cause nephritic syndrome and nephrotic syndrome or both, okay? Or both. You can have only nephritic, or both. So always pay attention what they mention about proteinuria. What is the amount of protein they lose daily? And if you have hematuria as well as more than 3.5 gram loss of protein, that means you have membranoproliferative nephritis with massive damage. Okay, then it means you have podocyte damage, you have basement membrane damage, and you have endothelial damage as well. So blood, protein, everything is there. That is one thing. Yeah, so complement activation, you understand, right? Type 1, again, type 1 gives subendothelial deposition and subendothelial, and it is related to hepatitis B and C. And type 2, you have deposition in basement membrane, within the basement membrane, and it is associated with nephritic factor. For that reason, it gives you nephritic syndrome, okay? Because of C3 nephritic factor, it can give a clinical picture of nephritic syndrome, okay? And that is type 2 membranoproliferative glomerulonephritis. So, more important point that is the type 2, I mentioned already. And again, how we differentiate based on deposits. Do you remember underneath the epithelium that's called subepithelium membranoproliferative glomerulonephritis, that is one type. You can get deposition under the endothelium, okay, that is under the endothelium, wherever you find is membranoproliferative glomerulonephritis, and if you get deposit within the membrane, that will be type 2. Okay, so we have membranoproliferative glomerulonephritis separately, and we have also type 1, and we have also type 3. Okay, and we differentiate based on location of the deposition. I see the deposit. Subepithelium, subendothelial, within basement membrane. And you know already, within basement membrane is type 2, which gives you nephritic syndrome as well. We have subendothelial, that is type 1 and is related to hepatitis. Okay? That is all you need to know. So convertase and this stuff is important, guys. C3 convertase, nephritic syndrome and stuff, that is important. I mentioned everything. And the last two cases, last two in pairs, you memorize minimal change disease, focal segmental glomerulosclerosis and sclerosis. Second one is these two, first two is nephrotic syndrome, where you don't have inflammation at all. Don't have. So immune complexes, you should not find there. But in the next two, like membranous and membranoproliferative, you must find immune complexes, and you can have nephrotic, either nephritic syndrome. And last two diseases is systemic conditions. Okay, last two diseases, mesangial proliferation is here. Okay, mesangial cells, mesangial deposit and mesangial cells. You see, this is mesangial cells here, and tram track appearance is this. You can see this is past staining, actually, past staining. And this is just hematoxylinosin staining. That is mesangial cell. multiple messenger cells you should find. Normally, messenger cells are few in the basement membrane. This is segments, okay? Collagen proliferation in the segment, focal segmental glomerulosclerosis. These both are membrane proliferative, hematoxylinosin, and past staining. Spike in dome, you remember where we have spike in dome? And what it is? You have deposition of immune complexes here in membranous, right? In membranous, you have domes, multiple domes, and between them a spike. Okay, systemic diseases. Now comes this diabetic glomerulonephrity, nephropathy. Okay. Systemic diseases, that is very, very important. Diabetic glomerulopathy, nephropathy. One is nodular glomerulosclerosis. Sclerosis, guys, focal segmental glomerulosclerosis. You find this word there, and in diabetic glomerulopathy as well. And sclerosis means you have deposition of not collagen but hyaline. Okay, here comes hyaline, and you understand this from, you know it from arteriolosclerosis, right? Remember Chymostil-Wilson disease? Okay, that is another name of nephropathy you find in patients with diabetic mellitus, okay? In diabetic mellitus. And what happens here, guys? Diabetic mellitus, you know what is the problem in diabetic mellitus? You have that they don't have insulin because they have damage of pancreas, and okay, they have high serum glucose. That is high yield. Pay attention, you have high serum glucose, and what does this glucose? Glucose is very toxic agent, right? It results to non-enzymatic glycosylation of vascular basement membrane. That is what actually caused damage of blood vessels in diabetic mellitus. Glucose is very bad. That's why you need to regulate your sugar level. Then, as you have this non-enzymatic glycosylation, guys, this basement membrane, vascular basement membrane, become leaky, okay, leaky. And what will be formed? Finally will be formed in the wall of the blood vessel, this protein leak because of basement membrane damage. You have accumulation of hyaline, okay? And finally, it will lead to hyaline arteriolosclerosis. Arteriosclerosis. So here you don't have collagen. Here you have hyaline, and as you have this hyaline, you remember hyaline arteriolosclerosis. We have two conditions, that is hypertension and diabetes. Right, hypertension and diabetes. And hyaline arteriolosclerosis in kidney, you find this pink sclerotic areas you find in glomeruli, and particularly which blood vessel will be affected. You should know that in diabetic mellitus, afferent, and afferents, you know, afferent is where the blood enters in the glomeruli, and afferent is from where the blood comes out of the glomeruli. So afferent arterioles are usually affected, okay? And as you have, that is important, pathogenesis you can explain from this actually. If you have damage of afferent arteriole, it will increase pressure in the glomeruli. Okay, it will increase. Imagine the blood cannot come out well because you have narrowing of this afferent arteriole because of hyaline arteriolosclerosis, and pressure increase in the glomeruli. Then what happens? It will lead to hyperfiltration. That's why you have proteinuria, guys, in diabetic mellitus, okay? Hyperfiltration is going initially it initially begins with microalbuminuria. In the beginning, you have microalbumin, and finally, it will cause to damage, complete damage, like sclerosis of this mesangium. Mesangium will become sclerotic finally, okay? And finally, you have this hyaline arterial sclerosis in blood vessel, and as you have increased back pressure, increased pressure in glomeruli, finally, this overfill hyperfiltration will lead to a sclerosis of mesangium. And here already you have accumulation of collagen. Okay, sclerotic mesangium means you have accumulation of collagen. How can you treat, guys? Somehow you need to decrease pressure in the glomeruli. Okay, and how you decrease pressure? You basically angiotensin you need to squeeze down, and some drugs are used here. You don't need it now. But what is important here? Okay, pathogenesis, you understand that we have this diabetes, and in both type, that is important, in both type. Chemostil-Wilson disease, chemostil-Wilson sclerosis is another name, okay. Hypertension, diabetic proteinuria, you definitely find. Pathogenesis, non-enzymatic glycosylation, afferent and efferent, but most commonly pathogenesis is defined with efferent arterioles, okay, that is important. Because of hyperfiltration damage of mesangium occurs, hyperfiltration damage. Why you have hyperfiltration damage? Because of increased pressure, right? You have hyaline arteriolosclerosis of efferent arterioles. For that reason, you have increased pressure in the glomeruli, and this hyperfiltration finally lead to damage of mesangium. And mesangium, you know VH, right? Mesangial cells are usually in capillary loop, okay? To put together everything, it's support of this whole capillary system. And finally, diabetic microangiopathy, you know it, microangiopathy, hyaline arteriolosclerosis, you should find. What are systemic diseases with nephrotic disorder, non-specific? Non-specific IF, you see, IF, guys, you don't have here immune complex deposition. For that reason, it is not specific. EM shows fusion of podocytes. Fusion of podocyte epithelial cells are damaged, obviously, because of hyperfiltration. Microscopic finding, definitely you need to find this hyaline arteriolosclerosis that is pink, deposition in around the arterioles, right? Here is not given, but efferent, guys, efferent is most commonly affected, and also microscopic, that is important. Hyaline arteriolosclerosis you should find, and nodular masses. And what are these nodular masses, guys? In mesangial matrix, nodules due to increased type 4 collagen synthesis, trapped proteins. It damages this basement membrane as well. And these proteins actually accumulate there and form nodules on the basement membrane. Clinical laboratory finding, microalbuminuria. Microalbuminuria, why? Because of hyaline arteriolosclerosis, you have narrowing of this blood vessel, which increase pressure in the glomeruli, and it will lead to hyperfiltration. And hyperfiltration will lead to microalbuminuria. That is, other renal diseases, renal papillary necrosis, you know already. It can lead to necrosis as well, complete occlusion of the small blood vessels, and it will lead to renal papillary necrosis, most common complication of diabetes, right? As well as pyelonephritis. And next disorder, systemic disorder, guys, is renal amyloidosis. So first disorder was diabetic nephropathy, and here is renal amyloidosis. What happens actually? It is very rare, very rare. You don't find in many cases, actually renal amyloidosis in multiple myeloma, guys. It is possible to find as a secondary complication in multiple myeloma, because you remember that in multiple myeloma you have deposition of amyloid. Amyloidosis of the kidney is, guys, you have deposition of the amyloid. It will lead to damage of the podocytes, and how it manifests clinically. Clinically, it manifests with proteinuria. And you have this location. If the question is, we are in systemic amyloidosis, deposit this amyloid. Amyloid will deposit in the mesangium. Okay, and this mesangial damage will lead to nephrotic syndrome. How are you going to make diagnosis? Congo red staining and apple green birefringence. You can memorize it. If you don't remember, it's okay, but definitely you should know that amyloid is stained with Congo red staining. Okay, that is nowadays even we use this Congo red staining. That was systemic nephropathy. And hereditary glomerular disease, Alport syndrome, guys. You remember we discussed it in nephritic syndrome, because it is damage of vascular basement membrane, because you have the collagen 4. Okay, you don't have collagen 4 mutation in alpha chain particularly. How are you going to make this diagnosis? Sensory neural healing loss, ocular finding, and kidney damage. Try it. If the end-stage renal disease is more common. Thin basement membrane disease, benign familial hematuria, it is also very rare. But you see, you can have this disorder with normal function. Okay, normal function. I have friend actually, that you can't imagine how rare this disease is, and she had this normal renal functions, just mild proteinuria. Okay, mild proteinuria because of this extremely thin basement membrane. Chronic glomerulonephritis is last condition in the group. Do you remember? We started here. Major group: primary, secondary, and hereditary. Hereditary and chronic glomerulonephritis. We had some where I mentioned. So chronic one, what happens in chronic one? Chronic, guys, rapidly progressive glomerulonephritis. That is chronic one. Focal segmental glomerulosclerosis. That is chronic. Type 1 membranous proliferative glomerulonephritis can lead to chronic one, because, you know, yes, it is definitely chronic. Once you treat them with chemotherapy, for example, you have to repeat this treatment once in a while. And these people usually live 10, 15, 20 years, okay? They can live with this disorder, okay? They don't recur, and but they have this chronic glomerulonephritis. That is important information as well. So causes. One is this focal segmental type 1 membranous glomerulopathy. Do you remember it was related to lupus? And type 4 diffuse proliferative glomerulonephritis in SLE. Immunoglobulin A glomerulopathy, it is in children. Do you remember? If it recurs many times, it resolves itself. But if you have multiple mucosal infection, several mucosal infection, for example, episodic disease, if you have, then what will happen? It will lead to progress to chronic one. Okay, so these are causes of chronic glomerulonephropathy. And gross microscopic finding, yes, that is shrunken kidney, glomerulosclerosis, and tubular atrophy. You know, it is chronic damage, and finally, kidney does not stop functioning well. Okay, for that reason, 15-20 years maximum. So imagine patient is young, for example, 30-year-old who has 30-year-old who has this lupus, for example, and finally has rapidly progressive glomerulonephritis. Maximum 15 a year is to live, so they will die younger. Oh, it is quite bad disease. This is schematic pictures, guys. For example, spike and dome. It is subepithelial hump. It is fine. Sorry, guys. Sorry, guys. So that is here, crescent formations. You see, only small part of the glomeruli functions well. This is focal segmental, small part is here. Here is mesangial problems, immunoglobulin A. In mesangium, you have this immunoglobulin A deposition. Do you remember? Subendothelium is a neutrophilic proliferation in lupus. You remember? And this is schematic view, just nothing about spike and dome is here, lumpy bumpy, same thing. What else? Nothing. This part you will see yourself. So guys, that was about glomerular diseases. I hope you understood it well, okay? And I don't have time to talk about infections, but trust me, infections are very easy and you prepare it yourself. That was our lecture. Thank you for listening. Your homework, my darlings, is glomerulopathology, infectious pathology, also tumors. Anyway, next week we will have quiz, okay? Quiz, and we will discuss everything. Revise whole kidney. That's it. Thank you very much, and see you next week. Bye.
Thank you.
Thank you. Thank you, doctor.
Bye.